tonight. So I just wanted to give everyone that heads up. Thank you so much. Okay, as I mentioned, my name's Katya. I'm a community outreach specialist with the Alzheimer's Association. I use she and her pronouns, and I'm very excited to be sharing this webinar with you all this evening on HIV and brain health. So it's a part of our LGBTQ Thrive with Pride series. I am excited we're very excited and grateful to have a guest speaker with us tonight, Dr. Joanna Helmuth. So I'll be introducing Dr. Helmuth and giving everyone a little bit of background about this webinar and why we put it together. So let me go to the next slide. Okay, thank you so much, Dr. Helmuth, again for being here. So Dr. Helmuth is a neurologist and researcher at UCSF, and really is an expert who works at the intersection of viruses and brain health, and specifically HIV-associated neurocognitive disorder, which we'll be learning about tonight. And she also works in the coronavirus lab at UCSF. And so Dr. Helmuth earned a Master's of Health Science degree at Johns Hopkins Bloomberg School of Public Health and completed her medical degree at the University of Vermont, and followed by a residency here at UCSF. So very excited for what I'm sure will be a very informative presentation. But before I hand it over to Dr. Helmuth, I just wanted to give everyone a little bit of background on this webinar. Just want to make sure, Erica and Danny, are you able to be co-host? Okay. Can you unmute?
I'm co-hosting.
Okay, awesome. Thank you. Okay. So the Alzheimer's Association, our mission is to end Alzheimer's and all other dementias by accelerating global research, driving risk reduction and early detection, and maximizing quality care and support. And we want to do this for all communities, which is why we put together this LGBTQ Thrive with Pride series. We know that the LGBTQ community has some very specific needs and issues related to Alzheimer's and other dementias. And so I'm very grateful to work with an awesome advisory council of community members who helped us decide on some of the health education content they'd like to see, and this was one of them. And so as I mentioned before, our mission is to end Alzheimer's and all other dementias. So you may have seen this slide before. This slide that defines dementia as this umbrella term for loss of memory and other cognitive or thinking abilities, and it's severe enough to interfere with daily life. So Alzheimer's disease is the most common cause of dementia. Between 60 and 80% of dementia is caused by Alzheimer's, followed by vascular dementia, dementia with Lewy bodies, and frontotemporal dementia. But we also know that we can see sort of mixed pathologies and other less common causes of dementia, like HIV-associated neurocognitive disorder, or HAND. And Dr. Helmuth will be sharing a lot on that. But we do know that the LGBTQ community is disproportionately impacted by HIV. So it's something that our community might be concerned about. So we actually worked with one of our national partners, SAGE, who provides advocacy and services for LGBT elders. And we published this LGBT and dementia issues brief a couple of years ago. And in that issues brief, which I'll put in the chat in a couple of minutes, there's a lot about HIV and AIDS and why it's a concern for the LGBTQ community related to dementia. And I recently attended one of SAGE's webinars, and I learned some of these statistics from the CDC, that over half of people living with HIV are over the age of 50. And by the year 2030, over 70% of people living with HIV will be over the age of 50. So this is in part due to some of the wonderful advancements in treatments for HIV, including treatment as prevention and PrEP and PEP. And Dr. Helmuth might be able to share a little bit more about that. But we know that many long-term survivors and people living with HIV are older adults, and age is the greatest risk factor for Alzheimer's and other dementias. So Alzheimer's and other dementias aren't a normal part of aging. Otherwise, we would all end up with neurocognitive disorders, but age is the greatest risk factor. As I mentioned, 1 in 3 after the age of 85, 1 in 3 people will develop some form of dementia. And we know that, as I mentioned, LGBTQ older adults are disproportionately impacted by HIV. And the LGBTQ community has other greater health disparities that are also risk factors for Alzheimer's and other dementias. But I also just want to say that even though the LGBTQ community is disproportionately impacted by HIV, viruses don't discriminate. And so we really just wanted to have this program to support the resilience of people living with HIV, long-term survivors who have endured so much stigma and discrimination over the years. The LGBTQ community experiences stigma and discrimination just for being out, a lot of times from healthcare providers. And so we really, at the association, want to work to reduce some of those barriers to accessing quality care and support. We want to make sure that everyone has an equal opportunity for an early and accurate diagnosis. And so I'm just excited to have Joanna Helmuth with us today to share about HIV and brain health and to support the resilience of people living with HIV. So I will now hand it over to her. And thank you so much again for being here, Dr. Helmuth.
Certainly. Well, thank you so much for inviting me to speak today. It's a real honor to speak with all you. Let me get my slides up here, and then hopefully I can share a little bit more about who I am and what I do and what I know. All right, let me pull that up. Right, can everybody see the slides? Great, okay. So again, my name is Joanna Helmuth. I'm a cognitive neurologist at UCSF, meaning I'm a neurologist, a brain doctor, but I specialize in thinking and memory changes. So I see people with all kinds of cognitive changes, Alzheimer's disease, Lewy body disease. But my subspecialty focus is in people living with HIV who have cognitive changes, and really in people who have had viral infections that are causing cognitive disorders. So I have a lot of patients living with HIV, and also a lot of people now who have had COVID, some with both, because they're actually cause a very similar cognitive disorder. So today I was going to talk a little bit about what we know about HIV in the brain. There's still a lot that we don't know, but hopefully to get everyone on the same page with what some of our scientific knowledge is and how we think about HIV in the brain and the risks that it may confer on some folks. So again, this just shares what I shared before about kind of who I am and what my background is. So I am a clinical researcher. So I spend some of my time in clinic seeing patients, but I also spend a lot of my time doing clinical research. So really trying to understand what's happening in the brain of people living with these conditions, because it really takes understanding these mechanisms to understand effective treatments and prevention for these kinds of cognitive changes. So we'll talk a little bit in general about what we know about HIV as a virus in the brain. We'll talk a little bit about how you can separate what is normal cognitive aging from what is HIV-associated neurocognitive disorder. I have a lot of people who come to my clinic and say, is this normal? Is this out of the range of normal? I have a loved one or a family member who had Alzheimer's disease. I'm really just trying to figure out what's going on with me. We'll talk a little bit about what we know we can do for cognitive issues, and then hopefully we'll have a lot of time at the end to answer any questions that you may have. So some of what we know about HIV in the brain comes from a very special research study that is ongoing now, that is happening in Bangkok, Thailand. So I was very fortunate to be able to work with this research group very early in my career. This is an acute HIV cohort. So this is a group of people who are identified within the earliest stages of HIV infection. And one of the reasons this is possible is because other countries are organized differently. And Thailand actually had the first anonymous testing clinic for HIV in all of Asia. And just because of their structure, they have a very centralized testing facility. So most people in a city of 20 million people get tested at this one anonymous testing clinic. Again, it's totally anonymous. But what they do is they identify, of all the kind of tests that are done at the end of the day, they take a small sample of that blood and pool it together and look to see if they can see any of the RNA or the genetic material of the HIV virus. Typically, we test by testing the antibody, but an earlier way to detect HIV is to see if we can see any genetic material of HIV in the blood. They find that someone that was in the clinic who got tested that day, someone tested positive. Then what they do is they kind of do these hierarchical algorithms where they kind of figure out who that person was. And then they contact them, again, anonymously, and say, hey, we think we found that you're in the very earliest stages of HIV that most people wouldn't be able to detect. We'd like to bring you in and start treatment. And are you interested in enrolling in this research study? And about half of people in this very earliest stage of HIV infection do enroll. So what they do is it's really this phenomenal study. Really the day of or the day after people are tested for HIV and diagnosed, we do a lot of mood assessments, cognitive assessments. We do blood draws, we do brain scans, we do spinal taps on people who are willing. And at the end of that first day, start antiretroviral therapy. So it's kind of an incredible amount of data that we gather on people in the very, very earliest stages of HIV. But what it does is by following these people over time, we're able to learn much more about what's happening very early in the course of infection in the brain. So it's allowed us to learn a little bit more about the timing of HIV infection in the brain. So we know that, there's some point in which individuals are infected. There's some latency or some lag time often between HIV being diagnosed and treatment being initiated, and then viral suppression actually being achieved through antiretroviral therapy. So I'm just going to have everybody do a little bit of a thought experiment. How early do you think HIV gets from kind of the blood into the brain? Knowing that the brain is a specialized compartment, it actually not everything that's in the blood gets into the brain. You don't have to provide answers, but just kind of think about how long you think it would take. One of the things that we found in this study was that the virus can enter the brain actually very early in the course of infection. The soonest I've seen is someone who's less than 5 days out from being infected that we can actually see evidence of the virus in the brain. But typically within the first 2 to 3 weeks of infection, everybody has detectable virus in the brain. One of the reasons that this is important is, again, there's this big lag time. Sometimes it's long, sometimes it's short, between infection and treatment initiation in contexts where treatments are available. So the brain sustains whatever damage or insult from the virus until that treatment is initiated. And so again, I think that it's kind of just important to think about the mechanisms of what's going on, that basically, the virus can be running rampant in the brain for quite some time with some individuals. So what happens once the virus gets into the brain? And so I kind of had this very complicated picture up here to show that basically what happens is that the virus gets in, immune cells kind of carry the virus across the blood-brain barrier into the brain. So we see that there are infected macrophages, which is a kind of white blood cell that can really carry the virus into the brain. And then once in the brain, the virus doesn't infect neurons or kind of the brain cells that we think of, but it possibly infects the supportive cells in the brain, these things called astrocytes, which kind of help the neurons function. And one of the reasons that I kind of present this complicated picture here is to show you that the kind of virus in the brain and then the inflammation that it causes is very complicated. So I think that we often think of inflammation as kind of this one sole thing. And if we just reduce inflammation, then, from all different sorts of causes, then, the problem will be solved, whatever it is that is medically associated with inflammation. But inflammation is not just one thing. it is all of these pathways and many, many, many more that aren't on this paper. And so just to show that inflammation is actually this very complex concept to understand when we're trying to figure out how a viral infection and inflammation kind of affects the brain or other parts. So what do we know? The virus gets into the brain early in the course of infection, and we know that people can present with neurological symptoms very early in the course of HIV. So in the same study, a number of years ago, we published a paper where we found that about half of people in this very earliest stage of HIV infection can have neurologic symptoms. Again, we found that about a third of people were having cognitive issues, problems with concentration, with kind of the effort that they had to put in to get tasks done, problems with their memory. About 25% of people had problems with slowed movements. And then, about 20% of people had problems with neuropathy or nerve problems on exam. So we know that the virus can get into the brain early. It also can cause problems in the nerves in the body as well, and that we'd see symptoms related to probably this inflammation related to the virus. We know that most of these symptoms we saw were right after diagnosis, and that if we, after we start antiretroviral therapy, most of these symptoms tended to go away, and the symptoms tended to be very minor. So I think one of the encouraging factors here is that we know antiretroviral therapy, if we start very early, can knock a lot of this down. I think, again, one of the challenges is knowing when you're infected, and so getting diagnosed and treated early. So, we've talked a little bit about inflammation. We've talked about the virus getting in the brain and causing neurologic problems. So what really causes these cognitive problems years and years later? Often when people come to my clinic who are living with HIV, who are noticing thinking and memory changes, we're not talking the first weeks and months of infection. Typically, this is years down the road that they're noticing these cognitive changes. In the Bay Area, most of the patients that I see have been on long-term antiretroviral therapy. And so if they're on antiretroviral therapy, why are they having the cognitive problems? I think one question is there injury that's happening before we initiate the medication? Is it happening in this kind of time period before people know they have HIV and before it's treated? Does antiretroviral therapy fully resolve the problem? Obviously not. So one of the challenges is that I think that we've learned over time that there is persistent inflammation. Again, another word we use is immune activation, despite antiretroviral therapy. So meaning that even though antiretroviral therapy knocks down the virus, so we can't, really detect it in the blood, that there's still elevated inflammation in the body. So we'll go more into that. So this is kind of probably an overly complicated picture here, but basically showing that plasma neopterin, which is a marker of inflammation of macrophages, those cells that I talked about earlier that carry the virus into the brain, that if individuals are just in the earliest phase of HIV infection, we see high levels of this inflammatory marker. If we start antiretroviral therapy, 6 months or 2 years later, that is lower than it was before, but it's certainly still higher than people who aren't living with HIV. So even though even if you start antiretroviral therapy really, really, really early in the blood, we still see elevated inflammatory markers in the blood. I will say I don't have a slide on this, but the brain is different. If you start antiretroviral therapy very early, we see no inflammation in the brain after about 6 months. And so something about starting therapy early really is protective for the brain, we think. We know that, even in people, again, who are treated with HIV, that there's neuroimaging studies that show that there's inflammation in the brain. Here's a study where they used a radioligand, which is basically something you inject in someone's arm and goes into the brain and then kind of attaches to inflammatory markers. And then if you do a specialized brain scan, a PET brain scan, you can kind of see that light up in the brain. And what it shows is that people living with HIV, again, even on virally suppressive antiretroviral therapy, can have neuroinflammation. And that this degree of inflammation didn't associate with a lot of factors we typically think of as worse disease, like how low the CD4 cell count, or people's age, or what regimen they were on, or how long they'd been infected, or the number of years since starting antiretroviral therapy. But we know that the more inflammation we found, or again, the other term we use is immune activation, the worse the cognitive performance in individuals. So there is this relationship between inflammation in the brain compartment and thinking and memory problems. So we know that this, inflammation, again, this other term, immune activation, persists despite antiretroviral therapy. So even if you start antiretroviral therapy early on, at least in the blood, we can continue to see this inflammation, and we see it in the brain as well. So I think one question is, why does this happen? Again, we're suppressing the virus. Why are we getting inflammation? Why is that causing these problems? And I think one of the leading theories at this point is that the virus that gets into the brain early on can form a reservoir there. We've talked, we're probably familiar with concepts of viral reservoirs in lymph nodes and in other parts of the body. It's highly suspected that the brain also can be a reservoir of HIV. And we think that there's very maybe low levels of viral replication that are happening in the brain, and that this kind of stimulates this low level of inflammation, or again, immune activation in the brain. And so the thought is, really the only way we're gonna get around this is to figure out how to get to those viral reservoirs and eliminate them, so we can reduce that inflammation, or treat really early in the course of infection so those viral reservoirs never form in the first place. So that's kind of some of what we think about HIV and the brain and inflammation, and why people living with HIV have kind of a different environment in their brain than people who aren't living with HIV. So kind of moving on to another topic, it's not uncommon for people to come to me and say, hey, I'm noticing some thinking and memory changes. I'm in my mid 50s or 60s or 70s. Is this normal or not normal? What's within the range of normal, and what's something that I should be concerned about as reflecting HIV-associated neurocognitive disorder? So, in most people, by their mid 50s, their brain starts aging. Like our muscles start aging, like our bones start aging. It's inevitable to some extent. And there's some things you can do to stave that off a bit. But most people around their mid 50s start having problems with memory retrieval, meaning that information is in there, but just retrieving that information. So coming up with names, coming up with words. Now, I really kind of emphasize that word retrieval, because we don't have a lot of words in our language to describe how our brains work. And nearly everyone I see in my clinic, regardless of what they're coming in, says, hey, I'm here with short-term memory problems. Because that's like something that's gotten out there, short-term memory problems. But the reality is that there's a lot of different kinds of memory problems. Short-term memory problems is what we see in people with Alzheimer's disease. That information never gets in there because the memory recorders in the brain aren't working. And so there's nothing to retrieve. But this is a different kind of memory problem we see in normal aging. Again, it's that information got in there, you're just not finding it efficiently. So it's really kind of a retrieval problem, which is a totally different part of the main brain than the memory centers of the brain. So difficulty coming up with names or words, some slower processing speeds. You realize it takes your brain a little bit more time to kind of come up with the information of what it used to. And most people say, it happens maybe a couple times a week, maybe at most once a day. This is kind of normal for what all my friends have who are my age. So that's really kind of encapsulates what we think of as normal cognitive aging. Again, maybe there's some things we'll talk about at the end that can help stave that off slightly. So what's abnormal then? What would kind of strike us as slightly different? And particularly for people living with HIV, there's this constellation of symptoms that we can see that really constitute something called HIV-associated neurocognitive disorder. So as far as the thinking and memory changes, we see that attention is really impacted. It's harder to focus on tasks. And because people don't focus as well on information and can't concentrate on it, it's harder to learn new information. And then you don't learn it, so you can't remember it. So it feels like a memory problem, but really it's an attention problem. People find they're more distractible. It's hard to stay on task. It's hard to get kind of larger projects done and kind of stay in line with all the steps of the process. People often notice that their thinking speed is lower, that they have a lot of difficulty multitasking. The brain isn't able to handle this much information anymore. It can kind of handle this much information at a time, and people can feel overwhelmed. And again, people can have a more magnified version of this memory retrieval problem. It's not once a day, it's many, many times a day that people are having problems retrieving names, retrieving words. Now, I said initially it's a constellation of symptoms because we also know that the networks in the brain that cause these cognitive symptoms, these executive function symptoms, we call them, also are involved in regulating our mood and regulating our behavior. So it's actually very common for people to have these kinds of executive function issues, but also have more irritability because their brain is less able to kind of pull the reins on their emotional responses. We also see that people have more apathy and depression and even anxiety. And I had a paper come out a number of years ago showing the more inflammation that you have in your blood in people living with HIV, the worse your mood scores are. And so it's almost thought that maybe this inflammation in the body is driving both thinking and memory problems and to some extent mood issues too. And then some people have movement problems. These are kind of in the realm of what we call Parkinsonian symptoms. They're not Parkinson's disease, but they look a little bit like it. Slowed movements, unsteady gait, poor coordination. I think that this is more of a minority of people, but it certainly can happen. So this is really kind of the constellation of what we think of as HIV-associated neurocognitive disorder. You don't need to have all the symptoms or kind of all the corners of the triangle. You may just have one or two, or maybe you have them all, or maybe you have just a few symptoms within each category. Everybody's kind of their own unique constellation in the sky. But I think what's emerging that's quite interesting is that COVID causes a very similar pattern of cognitive changes in some people. And mood symptoms as well. And we're seeing very similar associations with inflammation, particularly in the brain. What I'm kind of hoping is that we'll stop thinking just exclusively about HIV in the brain, but people become more broadly interested in what viruses do to the brain, because I think there's a ton of research dollars going into COVID. And what I'm hoping is that we can kind of learn in parallel and really boost our knowledge about this, but really just our cultural understanding too, that there's a lot of viruses that can cause persistent inflammation, then it can impact thinking and memory. But most of my patients living with HIV who have HIV-associated neurocognitive disorder live the same cognitive experience as people who've had COVID, who are dealing with post-COVID, whatever they call brain fog. I think that it might even be that it's silly to call it different things. Maybe it's all the same problem. And 10 years from now, we'll think about this very differently. So HIV-associated neurocognitive disorder, we've got these research categories of how we categorize it. Are you asymptomatic, meaning that you don't feel you have thinking and memory issues, but on testing you do, or that you have this mild impairment or HIV-associated dementia? This is a little bit academic because I think in the reality, in the context of antiretroviral therapy, there's almost no HIV-associated dementia. I'll be on, I'm one of the researchers that focuses on HIV in the brain and dementia. I've actually never seen a case of HIV-associated dementia in someone who's been on continuous antiretroviral therapy. I've only been a neurologist 10 years, but I've never seen a case. It always ends up being Alzheimer's disease on pathology or something else, a common disease that happened when people live long enough. So while this is certainly possible in the context when people don't have access to antiretroviral therapy, most commonly what we see is this mild neurocognitive impairment in folks. So again, we're still seeing a lot of cognitive changes with the advent of antiretroviral therapy, but it's really shifted. So we're seeing a lot less of this HIV-associated dementia. Again, I've never seen a case, but it apparently exists, and really much more of these kind of milder forms of HIV-associated cognitive changes. Sorry, it's gonna talk a little bit about the clinical course of hand, and then I'll kind of go back to these other slides. I realize these are a little bit out of order. So HIV-associated cognitive changes tend not to get worse over time. All right, I think a lot of people worry, if I have these milder cognitive changes, does that mean I'm gonna get dementia or gonna get Alzheimer's disease? Is this inevitably progressive course? And typically the answer is no. Typically it stays in the pretty annoying but milder range where people's independence isn't impaired. And they don't really reach that lack of or loss of independence that we think of as kind of the marker of dementia. That to be said, I have a lot of patients who have to go on disability. They're no longer able to function in their jobs anymore, but they can still drive a car or go shopping, things like that. Something that's interesting that is kind of emerging more is that there's some data to suggest that living with HIV doesn't necessarily increase your risk of Alzheimer's disease, even if there's this inflammation in the brain. We've done a lot of studies looking at Alzheimer's proteins in the brain. And if we see more Alzheimer's proteins in the brain of people living with HIV, and the reality is we just don't see it, that inflammation isn't really translating to more Alzheimer's disease. And so I think a lot of what we're seeing is reflective of people living kind of full lives and getting to the age where Alzheimer's disease is kind of a normal presentation. Now, I wanted to go back in my slides just a moment to say, what if this isn't HIV-associated neurocognitive disorder? There is this phenomenon called CNS escape of HIV that I do like to let people know about if you aren't aware about. So a lot of people think, okay, if I get my viral load done and I'm undetectable in my blood, that means I'm good. And I shared earlier that HIV can get in the brain very early in the course of infection. And what can happen if people particularly go prolonged periods of time off antiretroviral therapy is that virus can mutate to the environment of the brain, which is very different than the rest of the body, different cell type, different environment altogether. And so if the virus mutates to be very particular to the brain cells, then what can happen is that antiretroviral therapy that works for the rest of the body doesn't work for the viral form in the brain. And that causes something what we call CNS escape of HIV, or central nervous system escape of HIV. So you do a blood test, viral load is undetectable. But if you did a spinal tap and you looked for viral load in the cerebrospinal fluid, you'd see a detectable level of virus there. What's kind of scary is that maybe up to 10% of people who are asymptomatic might have evidence of viral replication in the brain, despite being undetectable in the blood. So we often think about this when people present with severe neurologic changes. Here's kind of a list of all the kinds of ways people can present with this escape of the virus in the brain: headache, memory disorders, movement problems, being comatose, feeling changes, memory changes. So, things that, certainly make a neurologist think. But again, if almost 10% of people who are asymptomatic might have some low level of virus in the brain, that can be alarming. If we do identify this, or we are worried about this, often what happens is we think about how well the antiretrovirals get into the brain, and then just see if it's possible to switch antiretroviral regimens to get something that's more penetrant in the brain. And often we can navigate things that way. But just to kind of, a lot of doctors out there don't know that if you do a blood test to look for viral load, it doesn't tell you anything about what's going on in the brain. It's a whole different compartment. So often in my patients living with HIV, I offer them all. I say, do you want me to do a spinal tap? We can either cross it off the list so we know that there's no actively replicating virus in your brain, or if we find that there's something we can do about it. But often we just don't know unless we look. All right, so we talked a little bit about HIV-associated cognitive changes. We talked about when the virus can escape in the brain and still be replicating, even if it's not replicating in the blood. What can we do for HIV-associated neurocognitive disorders? So one of the things that we want to do is rule out other causes. I want to, make sure that people don't actually have Alzheimer's disease, or they don't have some other cause of cognitive change. Sleep apnea is a big cause of cognitive change that looks a lot like HIV-associated cognitive changes. I now have patients who have HIV-associated cognitive changes and then got COVID and kind of dealing with both. So we really want to make sure that we can kind of manage things that are manageable, like sleep apnea, and they're modifiable. The next thing that we want to do is, again, we want to make sure that there's good viral control, not only in the blood, but in the brain. And this is often where spinal taps come in. Not everybody needs it, but often I'm more comfortable if we know than if we don't know. We know that there's other factors that can really impact cognitive performance. We know that people living with HIV are at greater risk for blood vessel changes or vascular changes. So it's actually incredibly important to have blood pressure controlled, to have cholesterol controlled, to have diabetes controlled. These all can damage small blood vessels in the brain. We know, again, HIV can do that too, and this alone can cause cognitive changes. We know for people who can tolerate it, cardiovascular or good aerobic exercise is one of the best things that we can do for the brain, other than be on antiretroviral therapy. And the goal is really about 30 minutes a day, or 2.5 to 3 hours a week of vigorous cardiovascular exercise. I'll admit I don't get that much as a working parent, but I wish I did, because we know people who get 2.5 to 3 hours a week of cardiovascular exercise, less likely to get dementia. So it's probably the one thing we can do in our day-to-day lives that most modifies our risk for cognitive changes. We also know that things like a Mediterranean diet over, many years can have some impact, and that cognitive stimulation and working on social isolation, which can be a big, issue in older individuals in the LGBTQ community, because a lot of people really had their community decimated in the 80s and 90s. That finding ways to create those social connections are really important, because our brains evolved to be in social environments. So when we're not using our brain, we're not using our brain to its potential, and we're possibly, losing function. So that's what I got for now. I'm happy to answer any questions that you have. I apologize if I took up too much time. But again, if you have questions related to this or kind of related issues, I'm happy to answer those for you. Thanks so much for your time.
Thank you so much, Dr. Helmuth. That was very informative and very helpful. You didn't take up too much time. I think we have a significant amount of time left for questions. I have some, and then I just have like a little bit more to share. What I had to share was a little bit more on like, yeah, what can we do? What are the recommendations for brain health? But you covered a lot of that as well. So I had a question about what you shared about the CNS escape of HIV, but I just want to open it up to everyone. If you have a question for Dr. Helmuth, also please feel free to utilize the chat. Okay, my question is, so did you say that that sort of happens when there's that difference between viral load in the body versus the brain? Is that typically when people take breaks from ART therapy? Is that what you mentioned? Or
it can be an increased risk factor. So again, a number of patients I see are long-term survivors living with HIV. And when they were infected, antiretroviral therapy was not an option, right? And so by default, they went, often many years or even decades from being infected to being able to suppress the virus to a large extent in the brain. And so the longer period of time the body and the brain are not exposed to antiretroviral therapy to suppress the viral load, the more time the virus has to mutate to specialize to the brain compartment. I almost think of it as like, it's still HIV, but it's a different kind of virus in the brain than in the rest of the body. And so people who went on drug holidays in the early 2000s when that was in vogue, people who didn't have access, people who have challenges and their psychosocial situation, which make it medication adherence increase the risk for that. So there's a number of things that we kind of look for that can increase that risk, but we know that it also can just happen in some individuals.
Yeah. Well, thank you for sharing that. And yeah, I think we really have come so far with treatments for HIV. It used to be a cocktail of drugs and they weren't as effective. And now, can you share anything about what's available now in terms of just like, instead of taking a cocktail, usually there's just one pill available for folks living with HIV. And I just want to say that that did not come easy. That came from years of fighting and advocating. The LGBTQ community has a really long history of fighting for all of our community. So I just want to acknowledge that. But yeah, do you have anything to share, anything you can share on, I guess, the advancements and developments in the drugs that have allowed people to live and thrive with HIV? I want to celebrate that, I guess, in so many ways.
Certainly. Yeah. And I really appreciate you pointing out how hard fought those successes were over a very long period of time. That one of the real kind of things that makes me just feel so honored to do the work that I do is that there's kind of this whole social justice aspect to HIV care and to HIV research that feels very different from other communities. I think that actually in a lot of ways, the LGBTQ community and people living with HIV have really changed the face of medical research in a lot of ways. ACT UP really made physicians and scientists and the NIH be responsible to the patients that they're working with in a very different way. And you see that manifest now in the COVID community. Right now, patient advocacy panels are a normal thing. Having community panels as a part of scientific research conferences are standard, whereas that was not the case. And that is only because people really fought so hard. I don't need to preach to the choir, because I know that you guys think that a lot of people in the medical field really don't understand this. But for me, it's a real privilege to be a part of a community where I'm held accountable as a community member, as a part of a bigger, structure that always hasn't treated people well. I don't primarily prescribe HIV medications to patients. Often I work with primary HIV providers in partnering in care when they refer their patients to me. But I think that what I'm struck by, even in my relatively short career compared to a lot of people, is how kind of wonderfully HIV is kind of on the back burner of medical issues for a lot of my patients. Their main concerns are many other things. Part of that is the community that we live in that's much more accepting. When I was living in Thailand, many of our patients would not even reveal their diagnoses to their parents, much less their employers, because it's still so stigmatized there. You lose your job if people know you have HIV. And around the world, we know that there is not the same growing acceptance. There's still so much stigma. But, it has been lovely working in a community where that stigma just doesn't exist. It's kind of like having high blood pressure. Like, we get it,
totally.
deal with it. It's just part of life, and there's no fault or problem. Like, it is what it is, and let's do what we can to help people's lives.
Awesome. Thank you so much for sharing that. Yeah, I completely agree. I had the privilege of also working in HIV advocacy right shortly after I finished my master's in public health. At the University of Sydney in Australia, I worked for a peer-led HIV advocacy organization. So I had the same experience where I think it really helps putting a face to this disease and understanding and learning the history of how hard our community has had to fight. The LGBTQ community has had to fight to be heard and get the treatments we need. So I appreciate you sharing that. And also earlier in your presentation, making that distinction that actually HIV dementia is very rare. You've never seen a case. And a lot of times it's really important to get that differential diagnosis. And oftentimes it's Alzheimer's disease instead of HIV-associated neurocognitive disorder. So someone had a question about that in the chat. So I'll just read that out and maybe you can clarify.
Sure.
So bottom line, someone says, would you say HIV increases the chance for the brain symptoms and conditions that you described? Is there a percentage increase that you can describe?
Yeah, so, well, we don't currently think that HIV kind of increases risk of dementia like Alzheimer's disease. You don't see HIV-associated neurocognitive disorder in people who aren't living with HIV. So there certainly is an increased risk. And we think a lot of that is that, that persistent inflammation that we see in the body and in many people in the brain. So that is what we think, at least at this point, is likely driving some of these differences. We know that about a third of people who are living with HIV who are on antiretroviral therapy experience these cognitive changes. So it's actually a pretty significant, portion of people living with HIV. So, I was told at the beginning of my career, why would you ever go into this field? We've got antiretroviral therapy. We've figured it all out. HIV isn't a field worth going into. But actually, quite a number of people living with HIV have some experience of cognitive changes. And most of this develops years after they've been on antiretroviral therapy. And so, again, if you're living with HIV, you have access to antiretroviral therapy, you have about, a 1/3 risk of experiencing cognitive changes. And that's a lot greater than person who's not living with HIV.
Yeah, thank you for sharing that. And some of that you mentioned is, I shared that statistic at the start that by 2030, I think 70% of people living with HIV will be over 50. So it's an older adult aging community. And yeah, I'm just really grateful to share all of these resources. We're sharing some in the chat that can hopefully provide information and knowledge. Knowledge is power. And we know that the earlier you receive an accurate diagnosis, the better health outcomes can be. So I'm sharing some resources in the chat from SAGE, from UCSF, I know you have a resource on hand, HIV-associated neurocognitive disorder hand. Okay, someone has a question. Is this a question on HIV, the HIV elder studies and imaging differentiated between hand and Alzheimer's clinical nurse now? I don't know if that's a question.
Yeah, I'm interpreting that are you asking, are we kind of clinically using AI to kind of differentiate between Alzheimer's disease and HIV-associated cognitive changes? Good question. So I was a part of the HIV elder study kind of earlier on in my career. And while it's kind of this exciting neuroimaging technique where we can kind of, use machine learning to differentiate between the two, the reality is you can kind of tell if you're kind of a well-trained neurologist, the differences between HIV-associated cognitive changes and Alzheimer's disease are pretty clear. The most kind of distinguishing way to determine that is actually based on cognitive testing profiles. People with Alzheimer's disease have these amnestic memory issues. They never learn new information efficiently because the memory recorder in the brain, the hippocampi, they're not working well. In contrast, HIV, this inflammation contributes to this executive function network problems, where we have problems with attention concentration. And so if we do detailed thinking and memory tests on people, it's actually very clearly disparate. So it's kind of a fancy thing that Dr. Valcour did to kind of get that out there, but there's actually not a need to get that complex with things because usually we're able to distinguish that pretty well. So perhaps one day we'll be using it maybe in the earliest phases of disease detection to try to differentiate more challenging cases. But right now there's not been kind of a clinical need to bring that into the clinic.
Thank you for sharing that. And there's another question that's kind of similarly along those lines around the process for diagnoses, differential diagnoses. What determines whether or not a spinal tap would need to be done?
Yeah.
Because you mentioned measuring some of that cerebrospinal fluid.
Yeah. So if I see a patient, they come into my clinic, they're noticing thinking and memory changes. They seem out of the range of what I would expect for normal aging. They're living with HIV. I offer all of my patients a spinal tap. I'll say, you don't have to do it, but they actually don't hurt as much as you think they do. They're pretty well tolerated. I do them all the time. I had a patient last week who told me getting a COVID booster was worse than getting a spinal tap. So I offer them pretty freely because I'm very comfortable doing them. And I know most people handle them very well and, aren't uncomfortable with me doing them. So I offer it to everyone because if you do it, you know the answer. You know if you have viral escape or if not. And otherwise, we kind of never really know.
I see.
There are certain cases where my index of suspicion and concern raises. So if you're a long-term survivor and you had years or decades where you did not have access to antiretroviral therapy, if you had a prolonged drug holiday, either in the early 2000s when that was in vogue or other times, if you have a lot of viral resistance patterns that have formed, particularly if there's kind of new onset neurologic changes that go with the cognitive changes that are raising my concern, I will often push a bit harder in these patients saying, I know you have some hesitancy. This is why I think that it might be worth doing. But ultimately, I leave it up to the patient. Not everybody wants a needle stuck in their back. I'm not going to force anyone to do anything. Again, there are patients where we find low levels of viral escape and they're resistant to all the medications out there and there's nothing to switch them to. So even sometimes if you identify it, if you already know that there's no options to switch them to, sometimes why go down that road if you can't even, address that question? And so if there's more drugs that come out, maybe at a future time point, it's worth doing. And so, again, not all doctors are comfortable with doing spinal taps as I am. Not all of them, feel like they can kind of assure people that it'll probably be a good experience and they won't be in pain. So there's kind of a spectrum of comfort in doing it. But I would say I'm the kind of person who wants to know. If you want to know, I want to know, because there may be something we can do about it. And I'd rather know something's not a problem, cross it off the list, never think about it again, or know it's something we're contending with and figure out the best way to come to a solution with that.
Thank you. Thanks so much. We have a couple more questions and we have about 10 minutes left. So I think we should be able to get to all of these. So yeah, it was really interesting what you shared about the similarities between like the brain fog you see with people with coronavirus, COVID, and that of those with hand. Um, and I also recently read a study on the link between the herpes virus, HSV, and cognitive changes. Someone asked if you have herpes as well as HIV, does that more increase your risk of dementia, or they asked of dementia, but maybe just cognitive changes?
Yeah. Well, I think that we're still learning a lot more about viruses and cognitive changes. So, one of the challenges here is that medicine has a culture just like everything else has a culture. Even if we pretend it's not there, it's there. And we've had these very rigid categories about how we think about the brain and study the brain, right? Like psychiatry, totally divorced from neurology in our training, when in fact it's both the brain, there's both processes of the brain that are going on, but for cultural reasons, it's very separate. Similarly, within the field of neurology, neuroinfectious diseases, viral infections that get in the brain, totally different community of people than people who study Alzheimer's disease and cognitive disorders. So I'm one of those like weirdos that lives within the world of like viral infections and cognitive disorders. Almost nobody else in my group does what I do. But there's just not a lot of people in this space because I think that people were being, didn't have a lot of humility in medicine, and they just assume, well, they're probably faking it, right? I think that you saw this with the beginning of the coronavirus pandemic. People were reporting all these post-COVID issues. Doctors never learned about this in school, and so it's easier to say, well, I think you're just anxious or depressed or stressed, as opposed to being like, guess what? We did the study. We proved that people have inflammation in the brain when they have cognitive changes after COVID. And so what the stage I'm setting is that there's not a lot of people that do this. It's really kind of an emerging and emerging of fields. But we do know that not all viruses do this, but some do. We know that hepatitis C can get in the brain and cause a cognitive disorder. And so it's really important to cure hep C.
Sure. There's a cure now, and the cure really is really recent. What year was it? 2018, I think.
I think it was, I think back when I was in medical school, over a decade ago, it kind of came out and it was like this big revolution. And so, we want to think about the viral infections that we can do something about. We don't really know much about two viral infections and if they cause additive problems or not. I will see that I have patients who are living with HIV-associated cognitive changes who get COVID who do worse. I have patients who are living with HIV who never had any cognitive changes and got COVID and aren't doing very well. And similarly, I've had patients living with HIV who got COVID who are fine, So I think that we still have a lot to learn. There's probably very individualized factors about our immune systems that put some people more at risk.
Yeah.
I would bet 20, 30 years from now, the field is going to be totally different. That we're going to think about this very differently. We're going to see like, what are your unique constellation of factors that are contributing to inflammation? And we'll also know much more about the pathways, about how to suppress that.
Yeah.
Maybe we can even prevent it. Maybe we can even stop it from happening before it starts in folks. So unfortunately, science takes a while, but I do think that while we don't know a lot, that we're still learning more and more every year about that stuff.
Yes, thank you. That's very interesting, and yeah, important to kind of, when we talk about risk, we kind of are starting to understand it in a similar way, your unique kind of web of risk factors, and it's different for everyone. And there's the non-modifiable risk factors, and then there's the things that are in our control, like those lifestyle interventions, cardiovascular exercise being the most important that Dr. Helmuth mentioned. But on that same topic about, people accessing care for their unique web of risk factors, someone was asking about basically how could someone access care at the MAC, the Memory and Aging Center at UCSF? Do you need to have a certain type of insurance coverage for treatment at the MAC? Or who would they be able to contact for that info?
Yeah. So if you go on our website, there's the clinical line, but it sounds like the person who's asking this question probably tried that clinical number and didn't get a response back. I honestly don't know the list of all of the insurance providers that UCSF accepts and doesn't. I know that we have a lot of problems seeing patients who are in the Kaiser system. I've actually had patients switch from Kaiser insurance to other insurance so that they can be seen in our clinic. There are other options available. So the Memory and Aging Center is trying to be less ivory tower, although we're pretty ivory tower, trying to get more into the community. So we now have clinicians that have regular clinics in a lot of community health centers across San Francisco. We also have a presence at San Francisco General in their neurology clinic. So many patients who aren't able to get into the MAC, the same providers that work in the MAC who are just, using their privileges at San Francisco General to act as providers and see folks there. And then sometimes that creates opportunities where people are able to get more access to care through the MAC if there's specialty things that can't be done. And so I would try calling the MAC clinic line, because often the staff support there can help kind of work through insurance issues. But if that doesn't work out and you're not able to get answers, I would kind of look to these other options within community health centers, even at San Francisco General and their neurology clinic, because again, I think it's pretty regularly our staff is there running a cognitive neurology clinic.
Thank you so much. I put a link in the chat. I hope everyone was able to click on that to the UCSF MAC's website. And I also want to say that I would think we might have some folks calling in not from the Bay Area. If you would like to do a one-on-one care consultation, we have a 24/7 helpline number, and we have a community resource finder online. So I will put a link in the chat to our community resource finder. You can find medical care. There's a number of options, everything from housing, transportation, medical care on our CRF, but also our helpline number is a great resource to be able to speak to a master's level clinician, and also just to have someone walk you through some care options for your unique situation. They can send you a list of providers in your area and really get that one-on-one support based on your insurance and all of that. So 800-272-3900 is our helpline number. And Dr. Helmuth put the link in the chat to Memory at UCSF.
And a lot of providers can see individuals by telehealth now. I think the pandemic has really opened that up. So we're only allowed to see people within the state of California for new patient visits by telehealth. But we see people. See people in LA. I see people all over the state. If you live in the state of California and you're out of state visiting or on travel, you can still have a visit with a provider. And so hopefully geography isn't as much of a limitation anymore, as long as there is internet access and technology access. But our providers are really good at calling people the 5 minutes before the appointment, walking them through how to log in if people are having cognitive issues and difficulty navigating that. Our providers and our staff are pretty experienced at doing what we can to help make that happen for people.
Thank you so much, Dr. Helmuth. We're getting a lot of thank yous in the chat. I'm not sure if you were able to see those, but really, really informative. And we're here to support the community, and just really grateful for the partnership with UCSF. So thank you again. And if you have any questions, don't hesitate to reach out afterwards. Thanks everyone for joining, and thank you, Dr. Helmuth. Everyone have a good rest of your evening. Take care.
Thanks so much for inviting me. Take care.
Thank you so much.